Hello everyone and welcome to today's webinar, Trauma Verification's April Q&A Web Conference. Please note that you should see your GoToWebinar control panel in the upper right-hand corner of your computer screen. By default, you have joined the presentation listening using your computer speaker system. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial information will be displayed. If you have selected mic and speakers and are having any difficulty hearing me, please toggle the telephone option in your control panel and dial in. If you're experiencing any other issues, please type in the details in the question section of your control panel and we will address them accordingly. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Thank you. Thank you everyone for joining today's web conference. I'd like to start off with our team. We got Tammy Morgan, myself, and Rachel Sanchez. And just for your information, to receive continuing education, you must attend at least 15 minutes of this webinar. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar, ending with instructions on how to claim those. If you have any questions during the entire presentation or shortly following the presentation, you may email us at cotvrc@facs.org. Just some housekeeping information. What is the goal for this webinar? It's to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. Understand the processes and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patients at your facility. So let's go ahead and get started. Some information. So if you are new to this webinar, please either have your hard copy of the resources manual or you can have a PDF copy which is available online. And I do want to stress, and this is, I didn't have this on prior webinars, but I do want to stress the importance of having the clarification document and the verification change log when you are looking at any of the standards, including the webinars, beginning with the webinars in June. So any clarifications are going to be listed on the clarification document, and any changes to a standard are going to be noted in the change log, and they're on our resources webpage. And I just sent out a monthly update for both of these documents. I believe it was on Friday. If you did not receive an email, you can contact us at the COT web inbox so we can add you to our distribution list. If there's been changes to your staff, that could be why you may not have received it. Again, both the change log and the clarification document are listed or posted on the webpage as we speak. Recordings of our webinars are available at all times, and they're on the ACS YouTube, and they're listed or posted on the resources webpage and on the address you see here. All questions are pulled directly from the questions you have submitted. There have been no edits made to the content. If your question is not answered today, the question may require more information and will receive a response from the ACS within a week. Or in some occasions, what happens is that it's a duplicate or it's a very similar question to one that we are answering in the webinar. Just some announcements that I am going to transfer to Rachel.
Good afternoon, everyone. The 2017 TQIP Annual Scientific Meeting and Training will be November 11th through 13th. This year, it's in our sweet home, Chicago. Registration for the conference will open in the summer of 2017. However, you can now make reservations for your hotel room. You'll find more information at the link listed there, and we recommend reserving your room early. Call for abstracts is scheduled to open Monday, May 1st. There will be a variety of pre-conference workshops in which you could sign up for. You'll see some of them listed below: the AIS and injury scaling uses and techniques, topic, optimal course, AIS 15 update. And registration is open for some of the workshops, and you can go to the link for more detailed listing. Molly will go over the next.
So as some of you are aware of, our next revision process is underway. We've talked about it here for the last couple of webinars, and now we're definitely getting into the revision process. We're doing it one chapter at a time, and then I think as soon as we start working on multiple chapters, then it may go a little quicker. So I just want to let everyone know where we are with that process. And if you have not yet provided any comments for any of the chapters or any of the standards, you may have concerns, you know, about CME, registrar, whatever the case may be, we're asking everyone to visit the Stakeholder public comment website, give us some information, give us your feedback, and if there's if you want to change, if you want to see a change, or if you want to see something added, be sure that you provide literature or any kind of documentation that will support that change to the new revision process. Just want to let you know we're currently doing or working on Chapter 6 for general surgery, so we are underway with that, and that actually is going to be our first chapter to kick off, and if that goes well and the work group work process is accepted, that's what we're going to use going forward. So the next couple of chapters you see here, Chapter 9, orthopedic, Chapter 10, pediatric surgery, and Chapter 15, registry, and Chapter 19 are the next ones that we're going to start working on. I will say that Olivia Montango, who is the PIPS program manager, has or will be sending out an email shortly to pretty much the same participants that I have about providing us information for Chapter 9 and Chapter 10. We need more feedback on how we can improve or change or retire any of the standards in those two chapters. So I would like to ask you to take time to go ahead and visit those two chapters or any of the chapters, but for the time being, Chapter 9 and Chapter 10 are the next ones in the queue that we're going to start working on in May and June. So I just wanted to point that out, and I will talk about a little bit more about this as we go on through these chapters. Oh, so another thing that we have just launched is a new tutorial that I've done, and this is primarily for new trauma centers and new trauma program managers who are new to our process. And this Becoming a Verified Trauma Center First Steps is a tutorial designed to help or guide the trauma program manager or medical director in how to prepare or request a consultation visit and the process and understand what our process is. And again, it's to assist them in preparing for a visit and what they need to do for a visit and what kind of documentation, when to apply for a site visit, a consultation visit, and how to what other information is needed. Again, it's available now. It's on our website in the resources webpage, and so I hope you guys take a listen or review to the new tutorial, and if you have any feedback on it, I'd love to hear what you have to say about it. And this is just a snapshot of what the first page looks like, and I do want to say that I will be creating a series of these first steps. This is the first one of Becoming a Verified Trauma Center, and we'll kind of launch those maybe quarterly or as needed. And I'm going to transfer this to Rachel for some scheduling reminders.
Thanks, Molly. Just a reminder, the applications for your site visit must be received in our office 13 to 14 months before your visit. And this not only gives you plenty of time to prepare for the visit and complete the online PRQ, but it also holds your spot for the visit. At this time, we are completely booked up to July 2018. Molly will go over the next few.
Yeah, so, and thank you, Rachel. So as Rachel stated, we have had a huge increase in site visits, so that's why we are requesting applications to be submitted pretty far in advance. And in the process of doing that, you also need to submit additional documentation that Anita will also need for the process. And one of those is the Orthopedic Traumatologist Leader Form, and this is for Level 1 trauma centers, including adult and pediatric and combined centers. So we do need that. I will say we do have a running list of those folks that have submitted the names of their traumatologists. So if you're uncertain if someone, if your OTL has either meets the requirement that we're asking they be traumatologist trained, Anita, you can actually reach out to Anita and she can actually confirm that with you. And the other thing we need is alternate pathway requests. I know many times trauma centers or the trauma program manager doesn't know at the time of the site visit application submission whether or not they need someone that needs to go through the alternate pathway. But the more time we have for that, the better we are, or Rachel is, to schedule someone to be present on your site visit, because one of the requirements is that if we're going through an alternate pathway that's never been through it before, you need to have a reviewer from the same specialty to be on site. And I will say with the orthopedics and neurosurgeons, we're very limited in reviewers, so we have to work around their schedules because they're just like anyone else, they're just busy, but we just don't have the number as we do for trauma surgeons and the nurse reviewers. So I just wanted to touch on that. Again, this is about the traumatology OTL form. Just a quick thing, if you're a combined center or if you're a level 1 adult trauma center with a level 1 pediatric center that utilize the same or share the same OTL surgeon, I just want to let you know we just need one form, where the second form just need, just the name and, what center they're working out of. Again, this is available on the website. You can look at this slide at any time, but we just need to know the name of them, and we do need the form so that Anita can validate that information. And again, this is the alternate pathway. I know a lot of people are confused about the alternate pathway, and I just want to stress that the only people that can apply, or the only physician surgeons that can apply for the alternate pathway, are those that are trained abroad and are board certified abroad. So if they're trained here in the U.S. or completed a residency here in the U.S. or in Canada and just never actually went and got board certified, this does not apply to them, unfortunately. So again, if you know that you have someone who has not gone through the alternate pathway, we need their name on the application and a copy of their CV, and then there's criteria that they need to meet during the course of that year that's listed on the website under alternate pathway criteria. So again, this is not for U.S. or Canadian trained. This is for anyone who trained abroad.
Okay. So this next slide is in regards to the pre-review questionnaire, the PRQ online access. So when your application is received in our office, you will get an email receipt, and your PRQ logins will be in the context of that email. So you'll want to hold on to that email. The online PRQ can be accessed at that link listed, and also a copy of the PRQ in Word can be downloaded from the link listed there. So we ask that you please do not submit payment with your application, because your center will be billed annually for the trauma quality program fee. This does not include fees for additional reviewers if needed. At the link below, there's a really great fee structure with the fees for the next 3 years, and we definitely encourage you to view that. So scheduling the site visit. You should receive your site visit dates by 90 days before your scheduled visit, give or take, and ideally all visits will occur during your requested time frame. When a lead reviewer is available for your site visit, I'll first contact the trauma program manager to confirm these dates. This next slide goes over site visit preparation, and this is more for a logistical point of view. Reviewers will book their own flights through the ACS travel agents, and they do this approximately 30 to 20 days prior to the visit. The hospital is responsible for the site reviewers' hotel accommodations as well as their ground transportation. You will have the reviewer's contact information once the full team has been secured, approximately 90 days before the site visit. But please be sure to contact the reviewers directly within 30 days of the site visit, just to email their hotel confirmations and get their flight itineraries and coordinate ground transportation to and from the airport, and any other site visit logistics. This next slide is in regards to confidentiality forms. Just so the centers know, ACS site reviewers have already signed a reviewer agreement containing a confidentiality clause and business associate agreement and this all happens prior to their first site visit. So these agreements, in addition to the BA, DUA that each hospital has with the ACS, should cover the needs of 98% of all trauma centers regarding confidentiality. But if your legal department needs some extra documents, such as other confidentiality forms, prior to the reviewers coming to the on-site visit, we ask that you please route these agreements through the VRC office, and you could do that at the cotvRC@facs.org email.
Thank you, Rachel. So we're going to go ahead and get started with general questions. So I had a question. Someone had asked me about the process for an on-site focused visit and what the expectation is. And there is a review agenda, a focused review agenda on the website available, so you can download a copy of that. But I do want to just go over what the expectation is for a focused review. So a focused review generally occurs following either a verification visit or a re-verification visit where there are some deficiencies cited. And what determines an on-site versus by mail type of focus review is the type of deficiency cited. So for example, if it's a deficiency about CME or peer review attendance or your trauma registry data or expert data not being screened, those things can be resolved by mail. However, if it has anything to do with the medical cases or reviewing your cases, medical records such as PI issues or loop closure, those things require on-site visits. So I'll talk about the on-site focus visit. So it's generally done in one day, about five hours. Within 5 hours it's done. And reviewers generally arrive the evening before. Depending on flights, it's the evening before if they're not locally situated or if it's not a hub. Otherwise, they can do it the morning of the visit, but generally the format that I have listed here is the evening before. So they'll arrive the evening before. One of the same initial reviewers will return, and it's possible that due to scheduling, you may get a nurse reviewer as a second reviewer, or it could be another trauma surgeon, but generally one of the same reviewers will return. We do ask the trauma center to provide us with a corrective action summary at least 30 days before the site visit. This way the review team has an idea going into your review or your site visit, knowing what was addressed and how that was addressed. And what they'll do is they'll validate that on site. There are going to be case reviews. So what we're asking trauma centers to do is you're not going to have nearly as many cases as you did during the original site visit. It's going to be probably a fraction of that, because what we want and what the reviewers want to see is any changes resulting from that deficiency that impacted the trauma program or impacted that requirement. We want to see cases where that was from the time that was implemented. So whether that was 3 months in or 6 months in, whatever the case may be, we want to see cases reflecting the changes made to your program. And I know a lot of folks talk about a presentation. When it's an on-site focus review, you can have a presentation if you like. It's not required, but you can. And sometimes it's beneficial for the reviewers that come in to see the presentation if you like. So again, it's a one-day review. If the reviewers arrive the evening before, they will approximately start at 700 in the morning, unless we've contacted you due to delays in flights or travel or something has happened. Again, chart review process, validating, and then there is a closed meeting with the reviewers, just like it would happen at an initial visit. And this is the time where you can have a discussion with the reviewers, whether they had any clarifications, something didn't seem right, so you can have that conversation at that time. And then there's the exit interview. So again, it could take about 5 hours, give or take 5 hours. Sometimes it's a little sooner, but they'll be there approximately 5 hours, and that's the end of a focus review. PRQ question, we're starting to work on our PRQ for late fall. I guess there's been discussion about the PRQs being pre-filled by TQIP data, whether or not that's true. I know we've talked about this, and I know a lot of folks ask about that. So this is definitely something we are considering for the future development of the PRQ. However, at this time and for the fall visit, anything this year and probably leading up to next year, we are not going to pre-fill any of the TQIP, pre-fill any of the PRQ with the TQIP data, at least not at this time. It'll be another year out before that happens. Ideally, that would be awesome if we can do that. Question about orthopedic section. There's a question in the PRQ about is there a mechanism in place to ensure operating room availability for musculoskeletal trauma cases can be scheduled without undue delay and not at inappropriate hours that might conflict with more urgent surgery or elective procedure. So basically, they're asking us what undue delay is, and what we're asking is that there is an operating room or a process by which the orthopedic surgeon can get in immediately or get in to be able to perform an open fracture, debridement, stabilization, and release of compartment syndrome. So they have to have the availability to get in there. And what that may take is having a relationship with the operating room management and personnel to, for a room. There are some centers that have a dedicated ortho room. We're not saying that's a requirement. We're just saying that there's some centers that have that ability, and there's also some centers that have the ability to bump a case. So you'll definitely need to look at what that structure is at your facility to determine what's the best practice for the orthopedic surgeon to get in there and do what they need to do. Again, another question about percent of femoral shaft fractures and what we're asking for. So this is good. It's clarified as the data is only for the tibial shaft fractures only. We don't want to, or I should say the orthopedic surgeons who review your reports following a site visit do not want to see any data that includes ankle, pylon amputations, and platus. So they want to just see tibial shaft fracture data only. Payer mix, great question, and I know we need to update the table. I think there's a conflict between commercial and HMO and PPO, and we understand that. So I want to say there's really not a wrong answer if you put it in one or the other, but I probably would recommend, and this is just my preference, I would recommend listing Blue Cross and Blue Shield as HMO, PPO, since that's what most people and reviewers are familiar with. Again, not a wrong answer if you stick it under commercial, so either or is fine. So we talked a little bit about this last month, and I do want to bring it back around because again, we are making ongoing adjustments to our PRQ. So in section 9 for orthopedic, question 18C, how many of these patients had neurological deficits? We are not expecting a response for that question, so you can go ahead and skip that question. And again, you may see a change. If you're working on a PRQ in the next several months, you may see that question actually, or question 18C, disappear entirely. Board certification for vascular surgeon. So does a foreign trained vascular surgeon have to go through the alternate pathway since they provide vascular surgery coverage for trauma? So the way I understand this, and I may need a little bit more clarification with the person who asked this question. So I answered this in the way that there currently are no ACS standards for the vascular surgeon who is providing vascular coverage. So for level 1s and level 2s, and this is a level 3 question, but this is for level 1 and level 2s, if they're providing vascular coverage because it's required for the specialty, we don't have any standards for that particular surgeon. But my last statement here, if the vascular surgeon serves as a member on the trauma panel, so if they're one of your trauma surgeons who happens to be just the vascular surgeon specialist, and they're providing trauma call as one of the members, they are required to go through the alternate pathway because they're serving on your panel as a trauma surgeon. So there is a distinct difference. So again, for the person who asked this, you know, if you can reach out to me, or I may follow up with you for more questions or more clarification. Question about self-reporting. Is it acceptable for the trauma surgeon to document their own bedside arrival time in regards to trauma activations? So we've said this is acceptable. I think what you want to do during a site visit is ensure that it's you know, if they're self-reporting, that it's validated, and usually it's done by the nurse scribe or a badge scanner or some kind of mechanism in your trauma facility. So I just want to ensure that that is being validated at your facility. PTSD, is screening for PTSD required for trauma patients at a level 1? And I had 2 questions about this. The second question was, is the ACS requiring 2 calls, 48 hours and 5 days, to follow up with all trauma patients to screen for PTSD and depression? So let me just start off that we don't have any standards for PTSD. I'm really not sure if we're going to have standards going forward. It's going to be, again, if it's going to be part of the revision process, we've really not touched a lot about this. The one thing we do talk about a little bit, again, not a lot, is that if you are going to screen for PTSD, again, the trauma center should develop guidelines on evaluating and treating and managing those patients with PTSD. So that is going to be an institution process, and it's not a requirement at this time, so just keep that in mind. So we're going to move on to CD-related questions. And trauma peer review attendance. So I had a couple of questions about this. Are physician assistants and nurse practitioners able to be the alternates for physician liaisons during peer review meetings? So I do get this question quite often, and unfortunately, they cannot serve as an alternate for the physicians. It's got to be a surgeon or physician serving as the liaison and also as the alternate for the trauma peer review meetings. When did ACS begin disallowing using observation patients towards the total trauma volume requirement? So I'm not really sure if there was a point in time where they were being used. I know since, and I'm probably dating myself here, but since the Gold Book, patients who were just present for observation were not part of the inclusion criteria, or I should say not part of the volume criteria, and that has been consistently the trend or the rule as of now. So any patients who do not meet the NCDS trauma inclusion criteria or are discharged within 23 hours, they cannot be used to meet the trauma admission criteria or volume. Transfer documentation. Trauma centers with affiliated freestanding ED, can ED nursing and MD documentation continue on same EMR note after transfer to us? So yes, they can. It is acceptable for the trauma center and freestanding facility to use the same EMR. I'm going to assume we're talking that they're connected in some fashion. So if that's the case, then the transfer and receiving information must be delineated and clearly documented in that EMR. So it is definitely acceptable. Question about non-surgical admissions. If non-surgical admission rates over 10% due to very high volume of ground level falls, what is recommended for the PI process on those? So really the PI process is the same as it would be for any patients, whether they're elderly or not elderly, but I just put this in here because it seems to be come up at every webinar. I do want to say, one of the things I want to say is it's okay to have your non-surgical admissions greater than 10%. We're not saying that if they are 10% or greater than 10%, if they're 30%, you're going to get a deficiency. The deficiency lies if you are not reviewing those cases that fall out after you follow the criteria listed on page 121. So after you filter all those patients out and what's remaining is greater than 10%, we want to make sure that you're reviewing those for appropriateness of care. So I just want to make sure that everyone understands that 10% rule. And again, this is just an example of what we mean about non-surgical patients, but also, defer to page 121. I think this is a similar question as the other slide is there a requirement to have a dedicated ortho trauma OR available 24/7 just as a major trauma room is? So what is in the book, proceeding 9.2 says operating rooms must be promptly available to allow for emergency operations on musculoskeletal injuries such as open fracture debridement and stabilization, external fixator placement, and compartment decompression. So this is definitely in your chapter 9 under orthopedic surgery. So it says a room must be promptly available, and as everyone knows, promptly is defined as 30 minutes, but there has to be a room available, whether it's dedicated again, or they can bump a case where the orthopedic surgeon can get in there and do what they need to do. It has to be available for them to do that. Otherwise, they will be cited as a deficiency or possibly, or cited as a weakness, possibly a deficiency. Neurosurgery and orthopedic surgery, can specialty PAs be included as backup call for those services that cover more than one hospital? It is acceptable if there are agreed upon guidelines between the TMD, neurosurgeon, orthopedic liaison for types of injuries. The resident or physician assistant, PAs or APPs will respond to when a consult is requested. So there must be clear documentation with the attending specialist surgeon on the plan of care. So there can be a plan in place for them to be backup or respond to the 30 minutes. So a question about the contingency plan. Can you clarify the neurosurgery backup call recurrent for level 3s if the neurosurgeons only cover one facility? So as many of you know, there's a lot of level 3s now with neurosurgery coverage or capabilities, I should say. If you happen to be one of those trauma centers, level 3 trauma centers that have neurosurgery capabilities, you're not required to have a backup call schedule. But if you do have these capabilities, the neurosurgeon and the neurosurgeon's encumbered, say if you have just the one neurosurgeon and they're with the in the OR, or the contingency plan has to have either a credentialing process to allow the trauma surgeon to provide initial evaluation to stabilize the patient and then transfer them out, or have a transfer agreement with the higher level verified trauma center and have direct contact with the accepting facility and monitor those cases through the PIPS process. I do want to say, if this is something that you have at your facility, and this is true for level 1, 2s, and 3s, I want to make sure that everyone is aware that for CD 8-5 in the PRQ, all these instances must be selected. Otherwise, what happens is it triggers a deficiency, or what we call a false deficiency, because either you don't have a credentialing process for your trauma surgeon, or it's just implied that your trauma surgeon is credentialed. You still need to check these off, but you have to have these processes in place if you are a level 3 trauma center that has neurosurgery capabilities. Pediatric trauma medical director, question for adult level 1, pediatric level 2, so this is a combined center that has a utilizing the trauma medical director as both the level 1 adult trauma medical director and the pediatric for the level 2. So it is acceptable. So we're trying to get away from using the word combined. So the way we're starting to respond to some of these is for a level 2 pediatric trauma center with a level 1 or 2 adult trauma center, the role of the trauma medical director may be served by the same person. What I want to stress is, as the pediatric trauma medical director, if that person is not board certified in pediatric surgery, he or she will need to meet the alternate criteria outlined in the clarification document. So as I mentioned in the beginning of our webinar, when you are utilizing or we're looking at our standards, you must ensure that you're using the clarification document and the change log, because what's written in the Orange book right now, it says the trauma medical director must be a pediatric board certified surgeon. We have made an alteration to this requirement that is noted in both the clarification and the change log, that if they are not boarded in pediatric surgery, there is an alternate metric that they can serve as the pediatric trauma medical director. So go ahead and refer to that document for more information. ICU, our APPs consider credential providers for ICU coverage to provide critical care. We have actually provided clarification that the intent for this is that an attending or the credential provider, which could be a resident or intensivist, to respond to the bedside within 15 minutes for critical situations, and that is documented. And any delays that impact care must be reviewed through the PIPS process. Radiologist peer review attendance. Question is from a Level 2 Trauma Center asking if the radiologist rep required to have 50% attendance, and the answer is yes. So for Level 1 and 2 only, the radiologist liaison or predetermined or predefined alternate radiologist must attend the peer review meeting at least 50% of the time. Surgical specialty care, what are acceptable ways to meet the requirement for hand coverage at a Level 2 trauma center? Does it have to be separate call? Can it be covered by plastics or orthopedic? Other options. Yes to the above. So hand coverage can be covered by plastics, OMFS, or orthopedic surgery. It doesn't have to be a separate call. It could be the same call. And as long as you can delineate on the call schedule what's what, and if the reviewers ask, then at least you have that information available to present to them. And I do want to stress the capability for reimplantation is not expected, so you can have a transfer agreement with another specialty facility that can care for those types of injuries, so that is acceptable. Question about advanced practice providers and ATLS. So I just, again, want to just stress the importance of this and clarify this requirement. The trauma and or ED department, ED, advanced practice providers, physician assistants, we use these terms interchangeably, who are members of the activation team, whether it's your highest or your limited, and are involved with the assessment or the resuscitation process, must be current in ATLS. If you have PAs or advanced practice providers who are just a scribe or just entering orders, or they're just, you know, they're just serving a different role, just not involved with the patient care, they're not required to be ATLS certified. Again, advanced practice providers, if trauma asks for a neurosurgery consult on a patient, and this is done by an NP, is that NP required to have ATLS? Again, they're not. The APs, the PAs, NPs, again, all interchangeable for us. If the trauma surgeon asks for a consult and the APs do respond, they are not required to be current in ATLS. The same would be true for the CRNAs. They're not required to be ATLS certified. Registrar, question is, one FTE trauma registrar is required for every 500, 750 patients. Can that include several staff, including entering data, and divide the hours up between the two people or the two staff members? And what I said here is the time may be shared between multiple staff to meet the 40 hours. However, if you're going to do this, so you have two people sharing the 40-hour coverage, you must ensure that each staff member meets the training requirement, and that means the that they've done 2 courses within the first year that they were hired or leading up to your site visit, that they've taken the AAIM course and another course to ensure that they are compliant with that requirement. Again, if you want more information on that, refer to page 110 and 112 in the resources manual. Question about mortality review. So all hospice cases have to be presented in monthly trauma M&M or just a case review. So I brought this back around because there's been some discussion, I believe, in the TQIP Google group about this, and there are a couple more questions out there that I will address, and I didn't want to address them here because I have not had a chance to look at them all, but I do want to say that if the death occurred while under hospice care at the facility, then that case will be reviewed. But if the patient is transferred, obviously transfer for hospice care somewhere else, you would not review that case under your death because they didn't die in your hospital. So the intent of this is, and what we're asking is that the center, what we are asking the center to do is review the hospice care up to the time the patient went into hospice. That's the intent that we're looking for. So there could have been major issues and that may have led to the decision to put the patient in hospice. So again, there's more questions out there, and I will address those, and I'll bring those back to the webinar for next month because they were a little different than what this slide was. Nursing education, the Orange Book does not specify nursing education. If an ER doc or ER does not have a dedicated trauma nurse, is that a deficiency? A couple of questions about this. Are there educational requirements for RNs caring for trauma patients? Again, when I talked a little bit about our revision process, this is one of the areas where I will encourage everyone to visit our Stakeholder website and give us some information on this and your feedback on how important this is for trauma centers. As it stands right now, there is not a specific requirement for having a dedicated trauma nurse in the ED. What the requirement that we have in the book right now for 17-4 says, the requirement is for hospitals to provide a mechanism to offer trauma-related education to nurses involved in trauma care. So, you know, it doesn't necessarily have to be a dedicated nurse, but if you're going to use your ED nurses, that they definitely should have some trauma education available to them by the trauma center. Universal screening for alcohol, ETOH levels and screening for all trauma patients are just trauma team activations for level 2s. Our clarification, what's in the clarification document, is universal screening for alcohol use must be performed for all patients that meets NCDS trauma inclusion criteria with a hospital stay of greater than 24 hours. So if it's somebody who meets NCDS criteria and was only there for 22 hours, we're not asking you to perform an alcohol screening on those folks. For pediatric centers or centers that do admit pediatric patients, the age is going to be defined by the trauma center, and what the reviewers are going to do is going to validate that the trauma center is adhering to that process. So I've got a couple of questions about CME. Excuse me. So panel members no longer on the schedule. So this comes up quite often, and I know there's always some turnover in trauma centers. So regarding CME hours, trauma call panel, PRQ and site visit, if the surgeon is no longer taking call during the reporting year, but was present during the call, or I should say was present during the reporting year, are CME hours for the surgeon who is no longer on the call required? No, it's not, and I've said this a couple of times. So for the PRQ, the data that is being reviewed or verified or validated at the time of your site visit is done retrospectively. So if there is a locum or a panel member that was there during the reporting year, but then, I don't know, left shortly before your site visit or shortly into the reporting year and is no longer present, you do not, number one, they do not need to meet the requirements because they're no longer there. And number two, you do not want to list them on your appendices because they are not there. Otherwise, if it shows up on your appendices and they're short, say CME or short on, you know, peer review attendance, again, it's going to trigger what I call a false deficiency until it's validated. So basically, the false deficiency will appear in the report the reviewers receive or prior to your site visit, and what they'll have to do is validate that at the time of the site visit, and it just is going to cause some confusion. So I would just not list them if they're no longer on the trauma call panel or taking call. I mean, if they were removed and they're no longer taking call, remove them. Don't list them. CME for board certification, a couple questions about this. For board certification, may the 33 hours CME be credited for either, or is it partial CME if it's board recert or initial board? Can you describe more completely how board certification is used for CME? Is that a one-time thing? Yes and yes. So we're allowing 33 hours of CME obtained from either the initial boards, either preparing for their initial boards or preparing for their recertification or part of their recertification or however that may be for that physician. So they can use the 33 hours and that is used once during the 3 years leading up to your visit. So if you're in your review cycle, which is the 3 years following your previous visit or during the first year leading up to your current visit coming up if you're a new center, however that may work. So it's once, you can use 33 hours once during that period. And if they're dual boarded, let's say they're boarded in general surgery and boarded in vascular surgeon, for example, we're only going to accept 33 hours for one of those boards. And what we have said, you don't need to break down those 33 hours for the boards. You just have to provide us documentation, not me per se, but the site reviewers on site. We'll provide them a copy of the transcript of their boards or a letter or something to the effect that they've taken their board certification and the number of hours that they have obtained, and the reviewers will just take 33 hours of that. For any other CMEs, to make up to 48 hours following the 33 hours, you are required to provide a summary face sheet, and you do need to break that down by the organization where they obtained the CME and what courses or what sessions they attended that are trauma related. Question about future change and how we're going to work on CMEs in the future. And great question. I love this question because I'm an advocate for making CMEs easier for trauma centers and easier for all involved. And we just, as I mentioned earlier, we started the revision process for Chapter 6, and I can't stress enough how many or how long the discussion takes on just the CME. I mean, it just consumes that discussion. So right now we are in the revision process, and what I'm going to say is I encourage everyone to please, please, please visit our Stakeholder website and provide us feedback, your commentary on your thoughts about the CME. And if you want to change in CME, we do ask that you give us some evidence or literature to support that change. A change is not going to occur unless we have literature and documentation to support it. So as of right now, we are discussing this. We are looking into making this easier and less onerous on the trauma center. So hopefully with your input and your participation in this process, we can make this easier for everyone involved. Prorated CMEs, we just learned that our neurosurgeon liaison will be leaving 6 months prior to our re-verification visit. Will his replacement be required to have 48 hours of external CME? So for the new liaison, so if it's a new appointed liaison, the CMEs are going to be prorated, or may be prorated, I should say, as 16 hours of external trauma related. This may include CMEs obtained from board certification, as I previously stated in the previous slide. So if it's someone new to the service, or as this particular person, their CMEs will be prorated. Now, I didn't put this on the slide, but if they're like 2 months into your service, they're so new, or new grad or new resident, it's expected they may not even have any CMEs because they're so new to the service. But if they're there 6 months or 8 months or 9 months, the expectation is that they have at least 16 hours of CME. Question about locums. For level 2, is it in need of a locum surgeon for a few shifts? What are the requirements? Unfortunately, regardless of the number of shifts, if you have locums on your service that are managing or treating trauma patients, the process is going to be the same as everyone else taking trauma call. So for all trauma centers, that's going to be, your credentialing process and board certification, peer review attendance for level 1 and 2. That's going to include CMEs, whether that's external or through an internal peer review process. So I just want to let everyone know that if you have locums, regardless of the number of shifts, it is required that they meet the same standards as the other members. Someone had asked, the IEP process is not well defined, and provide some examples. So what I did is I pulled some examples from a previous webinar, and I have put them on here. I won't go through them in detail, but I will say that there are some examples in the book. And so again, just a few slides on an overview of the IEP process, and this actually will differ for a lot of trauma centers. And what I will say to this is that the Committee on Trauma's Information Technology Committee, which actually have now changed their name, is currently developing a tool, and they're working on this as we speak, to help trauma centers, such as this person who's asking, to provide examples of IEP, or if someone has a really good IEP out there that they can share. We're going to have a website where we're going to house these documents, and it'll be accessible to folks such as this person. So we are working on this, and we're going to have more information as it becomes available. Again, these are all in the manual. What the IEP should reflect. It should reflect quality issues identified through your peer review, through your systems meeting, nursing, physician, chart audits. It should be regular regulatory mandates, Joint Commission, pain assessment, evidence-based, case-based learning. It must be able to document the activity. The TMD and the trauma program manager must have oversight over it and determine whether it's applicable to trauma. The one thing that a lot of trauma centers get confused about, where they see equivalent to 16 hours of CME, at this present time, that's a should. We're not asking that it's a requirement, but I guess what a lot of trauma centers are doing is they're just offering 1 hour of CE or 1 hour a month of internal education. So again, that can be determined however you see fit at your facility. If you do this, you have to make sure that it's clearly documented so the reviewers can follow your process and understand your process, and also verify who's participating in your process. Again, just a couple of more samples of what it looks like, and this is, again, is in your book. In-service case-based learning, it does not require CME or any other type of CE. Attendance, communication information must be documented. As I said, you need to have a mechanism where this is that the reviewers are able to verify this on site. And this is just a quick checklist of the IEP and what is needed. And again, this is available to anyone who is interested in following the IEP. And that concludes our webinar for today, and I want to thank everyone for your time and participating in our webinar. Thank you.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's April Q&A web conference. If you have any other questions, please contact cotvRC@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.